and HDL level, low HDL, and raised triglycerides. So everything, it's a part of the whole thing which we discuss as the dyslipidemias. Raised blood pressure, in my personal opinion, is one of the most ignored portion when you are going towards the modifiable risk factors. If a person is suspecting something, everybody knows it's a social message, very clear, smoking like and other things. But the most neglected part is from the blood pressure. In my personal experience, almost 1/3 of such persons who are at increased risk of ischemic heart disease or coronary artery disease or maybe the atherosclerotic disease, the most neglected portion is the proper diagnosis and management of the blood pressure. Diabetes is obviously, if somebody has it can be modified. If you control diabetes, control the HbA1c. One point reduction in HbA1c is linked with 10 to 20% reduction in the risk factor. We know dietary factors, lack of exercise, and all are these things which are a part of as a whole management. Okay, and obviously, if you look at the disease, what the disease is, it is the deposition of the cholesterol, which is leading to reduced lumen size. So obviously, the main culprit are the lipids, especially the LDL ones. So risk associated, when multiple risk factors are there, risk calculators are online, they are available. You put in the data, you find it. So if hypertension is there, smoking is there, hyperlipidemia is there. So 2 risk factors, 3 risk factors. So they multiply the overall risk as having an outcome of the coronary artery disease. So all these things we need to address as a whole. About the burden of atherosclerotic disease data is a bit older one, but 16.6 million people die. It was a relatively older data, and now the things, they are moving faster, especially in our region, in Southeast Asia and Sri Lanka. So the ischemic heart disease and the stroke, ischemic stroke, that is, it is becoming just like an epidemic, and the rise in number is more than twice which was anticipated maybe 10 years earlier. So it's a disease which is on the rise. There is no doubt about it. It may be the gift of the urbanization, but whatever the reason is, so there are multiple factors to be considered. Burden is on the rise. In 2013, the ACC-AHA blood cholesterol guidelines were there, and the important thing is that for statin benefit groups, the 4 groups were clearly identified in that. Number 1, the individuals, they are due to symptomatology and they are already diagnosed to have a atherosclerotic disease, whether whichever area is involved. If it is going towards the heart, it is a coronary artery disease, stable angina, unstable angina, maybe the myocardial infarction or coronary revascularization is done for that. If the region is towards the brain, then in that case, the TIAs, the ischemic strokes, and other things. But last but not least is the peripheral arterial disease. Especially this thing is sometimes more pronounced in the diabetics. In the diabetics, sometimes you are not having any symptomatology regarding the heart at that particular moment or something like that. But you may find the acral parts, they are saying loudly that the peripheral arterial disease, it is actually present over there, and whenever one of them is present, whether it's a peripheral or something, so it is equivalent to have the coronary involvement also. If a patient is having peripheral arterial involvement, so please take it as the TBL may be considered, it is equivalent to the coronaries. If TBL is having some problem in the foot, so the real problem, there would be something surely in the coronaries as well as the carotid system and other things. So you need to tackle it. So no doubt about it, this is the first group, statin benefit group, lowering the cholesterol, and with high intensity lowering, it would result in betterment of survival and other things. There are a few studies I would share later on, which clearly showed the benefit. The second group was an interesting group. It was free from any previous diagnosis, and even there was no age limit to that. that if any adult person is having LDL-C more than 190 twice checked, so regardless of anything, he was considered to be the group which can benefit from the statin therapy. It may be a 24 years old male, not having any significant risk factor other than a family history or whatever. But if the LDL is going above 190, so it was identified as a group which will get the clear benefit from the statins, regardless of the age. Previous guidelines, they were more strict towards the 40 and onward age groups, but for this special group having LDL-C more than 190, so there is no age limit to that. Third group, individuals having age between 40 to 75 and having diabetes already diagnosed. So if LDL-C is 70 to 189, that was so in this guideline it was labeled as. Recently it has become more blunt. LDL-C goal is now reaching almost to 50 now. You may say it now 50 to 189, that may be the group, but without clinical atherosclerotic disease. So diabetes, as we know, in the diabetes, the things are more atherogenic. The overall the position inside the vessel is favoring the atherosclerotic process to be accelerated. So obviously diabetes is taken equivalent to diagnosis of ischemic heart disease. So in that case, it was the third group which was clearly considered to be the reason. And the fourth group was that the individual without clinical diabetes or the coronary artery or vascular disease, but their risk calculation was done that was more than 7.5% or higher, 10-year risk, and age group is usually between the 40 to 75. So that was the fourth clear group which was considered to be the benefit group which can take the benefit from the statin therapies. We will take one by one. So two types of strategies they are emerging out of it. The first was the moderate intensity statin. It was for the primary prevention of the patient, especially with the diabetes, and the target was to reduce LDL from 30% to 50%. That was labeled as moderate intensity statin therapy. The next one was high intensity statin. So high intensity statin for the primary prevention in patient with a high risk group, that is more than 7.5%, and a patient who have already been diagnosed with having the atherosclerotic disease, whether it was a coronary artery syndrome, unstable angina, stroke, TIAs, or even the peripheral arterial disease involvement if the evidence is there. So it was the group which was considered to be having the highest intensity statin therapy is going to target these patients. So we have clear evidence we need to reduce the cholesterol for them. So when we look at the options that which in the statin therapy we can get, so clearly on the left you can see high intensity statin therapy. When you talk about high intensity statin therapy, you're aiming at a goal, the reduction in LDL-C more than 50%. So all these statins can't do this. So two main statins were in the front runner, atorvastatin in the dose of 40 to 80 milligram, and the rosuvastatin in the dose of 20 to 40 milligram was considered. So when a patient is having ischemic heart disease or equivalents in a full-blown and having a high-risk patient, so obviously the options for the prescription, they become focused on high intensity. And when you talk about high intensity, the two options are there, atorvastatin or rosuvastatin. But in the patient, when you are talking about the primary prevention, the LDL average reduction goal is up to 30% to 50%, less than 50%. So the options are more atorvastatin, rosuvastatin, simvastatin, the older one, and even the fluvastatin or pravastatin, and some neurish salt like the pitavastatin. They all out of them can be chosen accordingly. So message is very loud and clear that if your patient is going in that group which requires moderate intensity therapy, then options are open for all these statins. So you can choose any one of them. But when you are talking about high intensity therapy, especially when the diagnosis is already there, risk for 10 years coronary artery development is more than 7.5. So those high risk patients and already diagnosed patient, the target is high intensity statin therapy. Reduction goal is more than 50% for the LDL reduction. So in that case, only two players are main. One can be atorvastatin or the rosuvastatin. Okay. High intensity statin for primary prevention without clinical risk more than 7.5. So I'm going to share a few results from the main trials. High intensity was the first thing, and the trial which was done, it was the Jupiter trial. It was named after justification for use of statins in the primary prevention intervention trial evaluation. Rosuvastatin Jupiter, it was called. And in the details of the Jupiter, what was done actually, that almost 90,000 subjects were screened, and out of them 18,000 were randomized later on, and they were divided into two groups. So one is going to get the placebo, while the other one will get a rosuvastatin high dose, high intensity, that is dose in the 20 milligram. So rosuvastatin and placebo, the other things were comparable: age, race, sex, BMI, and almost the blood pressure, systolic and the diastolic blood pressures. Medical history, 15 to 16% comparable, smoker, family history. So all the things were comparable, and the only thing was placebo group was separated, and one was the study group, which is likely to get the active drug, which is the rosuvastatin. So the results, okay, here you can see primary endpoint was the first occurrence of a cardiovascular death, non-fatal stroke, or a MI, and you can see the two diverging things. Rosuvastatin showed a clear diversion at a period of 3 years, 4 years, and 5 years. There was significant reduction in the cardiovascular mortality. So it was clearly showing that the benefit of primary prevention, that the persons who are not already been diagnosed, primary prevention was the target. One group was taking the placebo, the other was getting the rosuvastatin, and the difference was, p-value was very significant, 0.00001 reduction. Overall mortality reduction was not that much impressive, but if you say it is around 20%, it has shown the benefit. But when we talk about the cardiovascular risk factors and the modification, so primary prevention was actually meant for the cardiovascular risks and other things. So it clearly showed almost 44% reduction in the primary endpoint for major cardiovascular events. Composite of CV deaths, myocardial infarction, stroke, unstable anginas, and arterial revascularization process. So Jupiter was the first trial in this thing, which showed clearly that if you are targeting the patient, if your aim is primary prevention, you need to prevent. So 44% reduction can be achieved in high risk patient with the help of high intensity statin therapy. Another trial was for the patient with already diagnosed clinical disease. So you can see various grades of atherosclerotic plaque is always is there, and the lumen is reducing. So role of high intensity rosuvastatin in slow downing the atherosclerotic progression. So it was designed to have the things, and the main parameter which was used in that was meteor background and the carotid intima media thickness, CIMT, over 2 years in asymptomatic patients at a low risk for cardiovascular disease. So the main thing is, when there is atherosclerotic plaque, the thickness of the wall and that thing is going to be increased, and lesser lumen diameter is available for the flow. So meteor trial was just to look at the things. If the high grade statin therapy, it can retard the progression, and later on this thing was further carried into it, and even the regression was seen in the disease process. So Study design was there. The patients were randomized, some getting the placebo, some getting the rosuvastatin, and the dose used was 40 milligram in that case. So obviously we are talking about the high intensity therapy group. Rosuvastatin dose 40 milligram was used, and patients were checked for the media interval thickening for at the period of 6 months, 12 months, 18 and 24. So they were followed up regularly for that. And it clearly showed that in the rosuvastatin group, the progression was much retarded as compared to the placebo group. You can look at the slide that the blue color the placebo is showing, and while the rosuvastatin is clearly showing the benefit in such secondary endpoints. So when accumulatively it was just postulated that in the Meteor trial that when you get the high dose statin benefit, so you can retard the wall thickness, and obviously that means you are going to reduce the disease burden and the progression. So the next trial important in the comparison of progression of coronary artery atherosclerosis of two highly effective statins. Now, one thing was established already that if you are going to retard the process, you need high intensity. In the high intensity in the beginning, I have already mentioned that you usually have only two players. It is a game between the atorvastatin or the rosuvastatin. The other statins, even in the full dose, just like simvastatin 80 milligram or pitavastatin full dose, they can't reduce the LDL up to that extent. So when you are talking about the retardation of the progress in a diagnosed patient, so atheroma is already there. So the only choice was between atorvastatin and the rosuvastatin. So there was a landmark trial, that is the Saturn study, which was comparing the progress with these two of the agents. To compare the effect of rosuvastatin, dose used was 40 milligram, while comparing with the atorvastatin 80 milligram on the progression of the atherosclerotic disease assessed by the intravascular ultrasound. So study design, patients were screened and then they were randomized. Finally, one group was taking the atorvastatin in the dose of 80 milligram per day, and while the other one was getting the rosuvastatin in the dose of 40 milligram. So what was the result? Flow of the patient, they were followed up and the atheroma was just evaluated for the volume and the progression and other things. So median change in percentage atheroma volume. So both showed the result that atorvastatin was able to reduce it up to -0.99%, while rosuvastatin showed the edge -1.22%. And overall, if you see the median change in the total atheroma volume, so atorvastatin in the dose of 80 milligram achieved -4.4, while rosuvastatin showed a clear edge that it went up to -6.4% median reduction in the atheroma. So you can say that the rosuvastatin not only showed the edge over the atorvastatin in that, and the dose was used was almost 40 milligram as compared to the 80 milligram. So when you use such dose, so it is considered to be that you are doing something with the disease which is a disease modifying process. If you can regress the atheroma, that means you are enhancing the lumen diameter, and it may benefit the patient in the long term as without any intervention. Normally when the atheroma is there, we need to go inside to put a stent or something. We're doing something with the balloon if you are going to that. But the medical therapy, it was a landmark trial we showed that with the help of only medical therapy without any surgical intervention or any intervention, you can reduce it to a certain extent. So the process is retarded, rather it is a disease modifying agent, it proved as. And the last but not least was then when you are talking about all this, so there was a stellar trial in which the comparison efficacy safety of rosuvastatin versus the atorvastatin, simvastatin and pravastatin across the board, it was done. So it was a study just to look at the relative efficacies and the dosage, the adverse effect profiles. So it is a very interesting study which showed the result. 6 weeks multicenter open label randomized, and the patients were given all the 4 drug options. They were randomized, and one group was taking the other, and the patients which were taken were more than 18 years of age, stable LDL cholesterol concentration between 160 to 250, and 2 consecutive visits before they were entered into the study. And the dosages were used: rosuvastatin from 10 to 40 milligram, atorvastatin from 10 to 80 milligram, simvastatin was up to 80, and the pravastatin was used from 10 to 40 milligram. Results were very interesting. So there was a maximum change in LDL which was evident was with the rosuvastatin group. You see the next slide, that is better one. Okay. So this one, the rosuvastatin achieving it up to minus 55% almost, getting into it, and the atorvastatin was a bit lagging behind that. And the very interesting thing was that the rosuvastatin achieved, if you can see in the middle one, the 20 milligram is mentioned in the baseline. So you can see the 20 milligram rosuvastatin reduced the LDL-C up to minus 52%. While on the other hand, if you can see that not more than 30% was evident at the dose of 40 milligram with pravastatin, and in the simvastatin, minus 46% was achieved with the dose of only 80 milligram that was used. While if you look at the rosuvastatin limb, minus 46 is done only with the 10 milligram dose. So it was very much clear that when you are comparing the efficacies, safeties, and adverse effect profiles, so rosuvastatin was clearly emerging out of it, because its 10 milligram dose was almost equivalent to 40 milligram of atorvastatin and 80 milligram of simvastatin, while pravastatin, the other one, was even unable to compete with this. So when you use a drug in such a lowish dose, so chances of adverse effect profile is also lowish. And in the dose of 20 milligram, it was rosuvastatin was clear winner. Minus 52% reduction was evident. So it was shown that if you further double the dose up to 40, so only minus 3% was getting the benefit. Same with the atorvastatin group, and nothing was done for pravastatin, as 40 milligram was the highest dose chosen. So the clear thing which emerged out of it was that rosuvastatin is in very much lesser dose was as efficacious as the older one. So if you look at the statin history, it began with the simvastatin. So simvastatin in the dose of 80 milligram was less superior to only 20 milligram dose of rosuvastatin. And if you talk about the 10 milligram, so 10 milligram was almost minus 46% reduction. It was superior to 40 milligram dose of simvastatin. So this stellar trial, it clearly showed that the days for the older one, they are gone. If you are looking for a high intensity reduction, and especially if you want to cross a 50% mark in the LDL reduction, if the receiving LDL is that much high that you are targeting at a LDL reduction more than 50%, so you are left with only one choice, that is rosuvastatin, because even the atorvastatin in the dose of 80 milligram was just touching to minus 51, while rosuvastatin was clearly above minus 55%. One thing I would like to share, as a clinician, you all listening, you are busy clinicians, you have your own experiences, but my lifetime experience is that patient do tolerate 20 milligram rosuvastatin very easily. Up to minus 52% reduction can be done. But on the other hand, if you talk about 80 milligram of atorvastatin, so that causes a lot of myalgias and muscle aches and fatigue and lethargy and so many other symptoms. So practically 1 out of 10 patients may be able to tolerate atorvastatin in a dose of 40 or 80 milligram per day. But when you come towards rosuvastatin, 9 out of 10 would happily, they will tolerate this dose without any significant adverse effect. So choice is quite obvious that in that scenario, if you want to look at that, and the patient comfort and tolerability, patient's compliance is very important. It's a long-term affair. If you are doing something to control the cholesterol, maybe at the age of mid-30s or even in the early 40s. So if you are talking about a patient, so it's a prescription which may suit the patient for 20 to 25 years per average. So if it is going to affect the muscle aches and other day-to-day activities, this thing must have some weightage. And it's my humble opinion that rosuvastatin in the dose of 20 to 40 milligram, especially if you just use 20 milligram, which is equivalent to 80 milligram of atorvastatin. 51% reduction with atorvastatin, while 52% reduction with 20 milligram of rosuvastatin. So as I have already mentioned that difference would be 1 out of 10 would tolerate atorvastatin, while 9 out of 10 would tolerate the rosuvastatin. So chances of tolerating the thing, sticking to the therapy, patient compliance, everything is going in the right direction when you are using the right choice. And the right choice obviously emerges out as 20 milligram rosuvastatin. So these are all the same, just showing the comparative data in that. And in the last, you can see the take-home message. So to use a statin to treat the risk, not the cholesterol, obviously we have already identified the 4 groups which can benefit from the statin therapy. So every patient is not even having the marginal high-risk cholesterol. It's not a candidate for statin therapy. There are 4 well-defined groups in which you will have to look into it. But when you talk about the high-intensity group, that diagnosis is already there, or the coronary artery risk disease is more than 7.5% in 10 years group. So high-intensity statin therapy is your aim. You want to give it to the patient. And in the high-intensity group, the rosuvastatin, it clears out as a clear, it has the edge on the other one. In this group, the only competitor was atorvastatin, and the rosuvastatin provides superior LDL reduction, superior primary prevention, superior atherosclerotic plaque regression. As in one of the trial, we have already discussed that it has a clear edge. It showed clear edge over 80 milligram of the atorvastatin, and beneficial for the patient undergoing the coronary interventions also. That is the diagnosed patient which is undergoing the interventions. So in all those groups which need high intensity therapy with the diagnosis or high 10 years high risk for the development of the coronary artery or the atherosclerotic disease, so the clear benefits were favoring the rosuvastatin in the dose of 20 to 40 milligram per day. So this is the take-home message, that if you are not going to intervene surgically, or you are not doing something percutaneous or the balloon angioplasties or other things, but the thing is, you can do something. If you can reduce the LDL more than 50%, you can retard the progression of the disease, you can modify the disease. The plaque regression is possible with the therapy. It has certain limitation. Obviously, it is not that much heroic as you may say that the stent placement would be, but it can do the things. And try to just take on the messages that try to prescribe something which is more patient friendly, lesser dosage with lesser side effects, and the patient compliance is maximum. As I have shared my personal experience, that for the same group, when I identified, so I found rosuvastatin very patient friendly in overall compliance as compared to the atorvastatin. Atorvastatin was much hostile. Almost 9 out of 10 patients, they came back with much complaints, and you need to reconsider the prescription in that case. You must all be knowing this already. Okay? So thank you very much for your patient listening, and if any question or query is there, you are more than welcome. Thank you very much. Okay, so first we have the question from Samar, What is the recommendation related to his induced myalgia? Should be continuous or dose adjustment is required? The myalgias, if they are there, you first need to just distinguish between myalgias and the myositis. Myositis is a thing when you get some tenderness in the muscle. It may progress to rhabdomyolysis. The creatine kinase, the enzymes, they are raised. So one thing is very much clear, that if a patient is having myositis as a side effect of the statin therapy, the statin therapy must be discontinued immediately. But when you talk about some myalgias, as I have already mentioned, that least chances to get with the rosuvastatin, as because you are using a low-risk dose. But if the myalgias are still there, you can add something. Number one thing is that statins, they are known to reduce the coenzyme Q10 levels, which is the cellular energy product. Blood levels are, they are going to reduce. So if you supplement the patient with Q10 supplementation, the myalgia incidence would definitely go down. And I have already gone through some of the trials which have claimed that lowish vitamin D level, serum vitamin D level, if it is lowish, then the incidence of the statin-induced myalgia, it goes up. So the side effect, it comes more frequent. So kindly check the vitamin D, serum D3 level, and try to maintain it above 32 nanogram per deciliter. And you can prescribe the Q10 preparation. So if you want to stick with the things, but one thing is very clear: if evidence of myositis is there, stop the drug immediately. If myalgias are there, so the things which can prove beneficial, it may reduce the myalgias. One thing is coenzyme Q10 preparation, maintain the vitamin D level, and sometimes the paracetamol type things, they may also help if you want to continue the therapy. Okay, the second question is from the same guy. Is the should you prescribe high intensity statin in primary prevention? Yes, obviously, high intensity statins, they are indicated if the patient is having the estimated risk factor, the estimated 10-year risk for the development of coronary artery disease more than 7.5%. So family history, aggressiveness is there, hypertension, diabetes, smoker, 2-3 risk factors. And when you go for the risk calculator, suddenly you find out that the 10 years risk is more than 7.5%. So yet patient is not diagnosed, so he is in the domain of primary prevention. But when the risk factor is going up, so we need to prescribe the high dose, high intensity statin therapy. And in my personal view, the 20 milligrams of statin is best in this group. It will reduce the LDL up to the target. More than 90% of patients, they will go into the target zone, and 20 milligram is far more better. It is tolerated than the 80 milligram of atorvastatin, which is the other choice. Okay, so I don't think so we have any further questions. So thank you very much for your patient listening. I hope the message was loud and clear. Thank you very much.